Good morning, everyone, and welcome. My name is Natalia Konovalova. I work as part of the Alcohol and Illicit Drugs program at the WHO Regional Office for Europe. And today I will be moderating this webinar session on alcohol use disorders, early detection and treatment. This webinar series is part of the WHO EU Evidence into Action on Alcohol project, funded by the European Commission. The aim of the project is to reduce alcohol-related harm in 30 countries, 27 of which are EU member states, plus Iceland, Norway, and Ukraine. As many of you know, this series started as part of a course which we developed for early career researchers interested in alcohol research. However, the interest was high, and we decided to open these webinars to a wider audience. Again, the topic of today is alcohol use disorders, early detection and treatment. And we will look at these two main strategies from public health perspective. We are joined by experts, Lidia Segura Garcia and Hugo Lopez. Lidia is a clinical psychologist specialized in addictions. She holds a PhD in psychology and a diploma in public health. Currently, Lidia is coordinator of the Subdirectorate General on Addictions, HIV, Sexually Transmitted Diseases, and Viral Hepatitis at the Public Health Agency of Catalonia. And just to note that the agency has been recently designated as WHO Collaborating Center on Substance Use, NCDs, and Policy Impact. Lidia is also an associate professor at the Autonomous University of Barcelona. She has more than 20 years of experience in managing and scaling up early interventions on alcohol and other drugs, mainly in primary healthcare settings of Catalonia. And our second speaker is Hugo Lopez. Hugo is a medical doctor and a specialist in psychiatry. Currently, Hugo is working as a specialist in the addictions unit of Hospital Clínic Barcelona and licensed psychiatry section in the same hospital. As well, he is a group leader of Health and Addictions Research Group of IDBEPS, which is the research institution linked to Hospital Clínic Barcelona. We are also joined by my WHO colleagues from the Alcohol and Illicit Drugs program, Maria Neufeld, Eric Carlin, Alexandra Olson. Thanks for joining us today. Okay, the format of the webinar will be as follows. First, we will have presentation by Lidia, who will focus on early detection and interventions for alcohol use disorders. After that, Hugo will tell us about evidence-based and cost-effective interventions used to treat alcohol use disorders. And in the end, we will have 10 minutes questions and answers session. As always, we invite you to ask questions in the chat. The experts and my colleagues from WHO will also be answering questions in a written form, and Eric will help to manage the chat. Thank you, Eric. With this, I would like to hand over to Lidia. Please, Lidia, the floor is yours.
Yes.
So, what do you think if we start with your presentation then?
No problem at all.
Yeah, thank you. Yes, we see your presentation.
Perfect. Well, thank you very much for your invitation to this webinar. And thank you for the kind introduction. I'm going to focus in the treatment of alcohol use disorder, not in the diagnosis, not in other aspects of alcohol use disorder, but treatment specifically. And I would like to start with this quote from Margaret Eleanor Atwood, writer and activist. War is what happens when language fails. Place change war by treatment and language by prevention. And we have a very nice quote for our presentation today. Treatment is what happens when prevention fails. So we have to keep in mind that treatment is not the best option, but it's the only option when everything before fails. Alcohol use disorder affect 5% of world population. It's more common in men than women, and more than 145,000 deaths in 1 year are attributable to alcohol use disorder. At the same time, it means that 21.5 million years of life were lost in one single year because alcohol use disorder. By direct deaths, for instance, poisoning, but as well by indirect causes like alcohol liver disease, which is one of the most relevant causes of death in alcohol use disorder. We have to keep in mind that alcohol use disorders do not necessarily coincide perfectly with heavy drinking levels. Most of heavy drinkers will have alcohol use disorder, but not all alcohol use disorders are under heavy drinking levels. I'm going to explain with more details in the following slide. Alcohol use disorder is a clinical diagnosis. It's not just quantity or frequency. Biological symptoms like tolerance, withdrawal, or craving are present, but as well medical harm symptoms like continuing use despite medical problems, regular drinking, even with physically hazardous, behavioral symptoms like uncontrolled intake, unsuccessful efforts to stop, a lot of time spent around alcohol and getting alcohol, and social and functional harm like reduced activities, use despite social or interpersonal problems, and failure to fulfill major role obligations. Despite these criteria are not perfect, but helps clinicians to diagnose alcohol use disorder and to find an appropriate treatment. This diagnosis is based on patient report, relative report, other colleagues report, clinical records, and biomarkers. It's quite relevant to keep in mind that exists a continuum of care in alcohol use disorder. If we go to the basis of these parameters, low-risk alcohol use without alcohol use disorder, treatment is based on community. High-risk alcohol use and brief interventions are used commonly in primary care. Lidia will explain later a bit more. When we move to the next step, alcohol use disorder, both moderate and mild, psychological treatment are the base of the treatment. For some cases, the most severe cases, pharmacological treatment is also needed. Alcohol use disorder are usually treated in specialist centers, but the transition from primary care to specialist centers are known as referral to treatment in the SBIRE model. Lidia will explain later for sure. And it's part of the treatment itself to get the patient access to treatment. According to measure recommendations, treatment for alcohol use disorder and substance use disorder in general should be comprehensive approach. That means that the patient, the user, is in the center. and all the service may need to be provided in the same center, if possible, and if it's not possible, to facilitate the access to treatment to all the service. And when we say all the service, we refer to mental health, to alcohol use disorder treatment, to treatment of comorbidities like HIV or other viral infections, social support, other healthcare needs. This is the gold standard. There are several objectives of the treatment, and we have to personalize according to patient situation and patient's opinion. The classical abstinence goal is useful for many patients, but other patients only can commit with alcohol reductions, and in other case, harm reduction is the gold standard for them. So we have to find the goal for each patient to personalize the treatment. But in almost all treatment, social care, psychological treatment, plus digital health interventions in many cases, and in some cases, pharmacological treatment are the pillars of the treatment. So I'm going to review these three pillars of the treatment. Pharmacological treatment, it's not for everybody, but some patients, the more severe cases among the more severe alcohol use disorder patients, need detoxification in the first week after stop drinking if the aim is the abstinence. And detoxification is based on benzodiazepine with a strong body of evidence in favor of benzodiazepine over other medication, and thiamine to prevent Wernicke-Korsakoff syndrome. In the second step, after 1 to 2 weeks of detoxification, there are drugs to prevent relapse, and we have a very good number to treat, number needed to treat, and it's comparable to other treatments in psychiatric medicine in general. As well, we know that both behavioral interventions and drugs are cost-effective to treat patients with severe alcohol use disorder, but they are underutilized. For instance, this is a cohort of more than 125 patients, 125,000 patients, sorry, in Sweden, and they explore what happened with patients under treatment for alcohol relapse and prevention against those who have alcohol use disorder but didn't receive treatment for alcohol use disorder. Naltrexone and camprosat reduce risk of admission to hospital for any cause. So in this study, the main finding is that medications to prevent relapse reduce hospitalization. Evidence-based psychological interventions for alcohol use disorder with a stronger body of evidence are motivational interviewing, Alcoholics Anonymous, and other 12 steps programs, cognitive behavioral treatment, and contingency management. And this is a study of our group. We ask the patients why they go to serial urine testing to our unit. We ask the patients to came to our unit to take a sample of urine and testing alcohol and other drugs 1-2 per week. And we ask them about their motivation to do so. And the main motivation was to get my therapeutic objective, to prevent relapse, more than to show professionals of my family that I'm in abstinence. So urine analysis is useful as well as a kind of contingency management, helps the patient to be committed with the treatment. Now we have digital health intervention as well. Digital health interventions with a strong body of human evidence in primary prevention, but as well in secondary prevention, have a potential major role in tertiary prevention or treatment, because facilitate treatment initiation and adherence and promote self-management and self-care. Some examples are games, serious games or video games designed to increase awareness of any health problem, in this case alcohol. Virtual reality, for instance, for cognitive remediation or to manage the craving of alcohol use. Text message as a reminder of treatment appointments, for instance. The universe of digital health is huge, and we have a lot of examples of instruments, both for primary, secondary prevention, but as well for treatment. And one very nice example of this is just-in-time adaptive intervention. This is a kind of intervention that provides to the patient feedback in the right type of amount of support and in the right time. So, for instance, when the patient is in risk of alcohol relapse or alcohol use, he or she receives a message in the mobile phone with information to reduce the risk. And how they know that the patient is under risk, for instance, because GPS informed that he or she is very, very close to a zone, plenty of bar or restaurants, for instance. This is an example of promising individualized treatment. Other example, this is from our group. We are testing in a randomized controlled trial a serious game. This video games is focused on patients affected by a recent diagnosis of alcohol liver disease and alcohol use disorder, and try to increase awareness, increase adherence to treatment of both alcohol liver disease and alcohol use disorder treatment. The serious games has 6 weeks, and the patients every day spend 15 minutes in solving a challenge which is a game. And every game is designed to communicate some relevant information about the disease, about alcohol liver disease or alcohol use disorder. And to carry out this challenge, they come with the help of virtual professional in each step, so they can familiarize with a pathologist, with psychiatrists, with psychology, with social worker, etc. And we have a strong narrative. The patient is doing a journey. The journey is to get the heel of a mountain with the name of Whale Bang Hill. And during 6 weeks, the patient will do this journey with the help of professionals to get this hill. It's a metaphor of the treatment of alcohol use disorder and alcohol liberacy. It's also relevant to take into account the social care. The most severe case of alcohol use disorders are associated with low education level and especially unemployment. So measures to support the patients in the treatment, to support the patients in the social care, it's relevant. This is a very good example of harm reduction, which is the housing first. In brief, is to facilitate a house to the patient regardless the alcohol use status. And after having a house, you can work with the patient about alcohol use disorder in other aspects, for instance, with psychological treatment. Housing First has shown in this systematic review and meta-analysis of randomized controlled trials that reduce emergency department visits, reduce hospitalization, reduce time in the hospital, and the patient, the user, spend more days in-house, are more likely to be in-house after 1.5 years, 2 years. Other relevant aspect of the treatment of alcohol use disorder is the treatment of comorbidities. 1/3 of patients with alcohol use disorder has at the same time other mental health disorder. The most common are depression, anxiety, post-traumatic stress disorder, and an attention deficit and hyperactive disorder. And mental health disorder and alcohol use disorder is associated with increased admissions, increased suicidal behavior, increased comorbidities, poor prognosis, more risk of relapse in both conditions, more unemployment and lack of housing, and more risk to be a victim of violence and crime or perpetrators of violence and crime. And we can forget cognitive impairment as a comorbidity. 70% of patients with alcohol use disorder have mild or moderate cognitive impairment, and 25%, only 25%, are real dementia. But in any case, cognitive impairment is associated with a high impact of quality of life, more risk of relapse, more drinking days, more heavy drinking days, more psychiatric comorbidities like depression or anxiety, reduced adherence and retention, less self-efficacy and motivation. This is one of my last slides, and it's to highlight that access to treatment in alcohol use disorder is very low. Some estimations inform that only 10% of patients with alcohol use disorder access to treatment. And this is because patients' barriers, for instance, low insight, low motivation, lack of support in the social environment, difficulties to communicate the status, the healthcare, the health status or the pattern of use status, but as well because lack of training of healthcare workers, difficulties to screen and treat these patients for the healthcare workers. But, and probably this is the most relevant barrier in my opinion, because organizational and logistic problems. sometimes the organization of treatment and the access to treatment is not easy, and we need to do an effort to make easier the access. For summarizing, prevention is the best treatment for alcohol use disorder, but when prevention fails, continuum of care is essential and comprehensive treatment the best option. Multidisciplinary approach should be the gold standard, social care and psychological treatment for sure, and pharmacological treatment only with more severe cases. Don't forget comorbidities and harm reduction. They can make the difference for many cases. And we have digital health interventions that may facilitate treatment, increase adherence, and improve empowerment. We need to improve our knowledge of how improve the implementation of digital health interventions to be more common in the real world. Thank you very much.
Thank you very much, Hugo. I think we are just right on time. And indeed, the best treatment for alcohol use disorders and not only is prevention. And we will now hear more on this from Lidia. The floor is yours, Lidia. Welcome.
You hear me?
Yes.
Good morning. I'm sorry I had some technical problems at the beginning, but I'm glad I'm here now. Yeah, I'm gonna share my screen. Hopefully everything works. You see it now?
Yes, we see it very well.
Well, thank you very much for the invitation. Well, let's start with the fact that in all the policy planning related with alcohol, it is clearly stated that facilitating access to screening, brief interventions, and treatment is key. As you can see here in the SAFEN initiative from WHO, health professionals have an important role in helping people to reduce or stop their drinking, to reduce health risk and health services, and have to provide effective interventions for those in need and help and their families. It is very also relevant that in the last updated menu of policy options and cost-effective interventions, it is still included providing brief psychosocial interventions for persons with hazardous and harmful alcohol use as a key policy option related with alcohol. And in addition to that, in the last updated version of the alcohol ordinary commodity book from Baber and collaborators, again, brief interventions for non-dependent high-risk drinkers, behavioral and psychosocial therapies, pharmacological treatment, and mutual health interventions are stated as good practices. So this is like the guiding principles of our intervention. And the good thing is that this policy is only based on health, the health sector. So we have complete autonomy and capacity to implement such a strategy, such policy option. And it's not the same, for example, with other policies that are relying with other departments. So it is important to have this in mind. As Hugo was mentioning, in the continuum of alcohol-related problems, we have to adapt the interventions according to the level of risk. And SBI is aimed at preventing alcohol and problems, and mainly we have to target people with low risk alcohol consumption and hazardous alcohol consumption, and including also in some stages a harmful alcohol use. But mainly we will focus on this this level of problems, mainly this, but also including harmful, because as a statement, these people can still have some control of their alcohol consumption, and they can of course reduce it through a good advice from professionals. But what is SBI? Is of course the NOR spirit, as we were mentioning, is the acronym for these three components: screening, brief interventions, and referral to treatment. Screening, you might know this, of course, but this is part of the strategy to early identify alcohol problems, and you can use it, do it by using standardized questionnaires or screening questionnaires. Usually, these screening tools are self-completed completion questionnaires, so done by the person itself, but also through the professional, and are short, usually short questionnaires. This early identification approach should lead either to further assessment or to, because we might find that this person fulfills criteria for harmful alcohol use, and or to a brief intervention or to specialized treatment, depending on the needs of this of the level of risk. There are, in the literature, you will find a lot of screening tools for alcohol, but mainly cage, audit, and mask are the most commonly used. However, the most popular one and the most widely used is audit. Audit is the alcohol use disorder identification test, was developed by WHO as a tool to screen for alcohol use disorders in various populations. It's a 10-item audit tool and assesses three conceptual domains: alcohol intake, quantity and frequency, and items 1 and 3, dependence from items 4 to 6, and adverse consequences items 7 to 10. The audit is scored by summing all the values and up to 40, and the proposed categorization for alcohol use disorder is the following. Can categorize people among these levels of these three levels: hazardous drinking, a pattern of alcohol consumption that increases the risk of harmful consequences for the use of others; harmful drinking, which results in consequences for physical and mental health; and dependent drinker, cluster of behavioral, cognitive, and psychological phenomena that may develop after repeated alcohol use. And it's over 20 in the score of audit. This cut of scores, mentioned here, and alcohol standard units associated vary across countries. We need to have this into account. And Audit C is a development of the Audit 10 questionnaire. It's actually a short version. It includes only questions 1 to 3, that is quantity and frequency questions, and allows identifying only hazardous drinkings. And so the idea is that you usually use the Audit C as a first screening tool. If we get a positive score from 4 plus over 4 as a cut score, then we will continue with the Audit C, and we then can identify all these three levels of risk. Do you see it now again?
Yes, but from the first slide. So now you are moving, you are scrolling down.
Yeah, let's see if it works out now. Okay, sorry. When it comes to brief interventions, are short and educational interventions grounded in social cognitive theory aimed at promoting behavior change, and typically incorporate the following elements: feedback on the person's alcohol use and alcohol-related harm, and clarification as to what constitutes low risk or high, or what kind of risk this constitutes, information on the harms associated with this risk alcohol use, benefits of reducing intake, advice on how to reduce intake, and motivation enhancement, analysis of high-risk situations for drinking and coping strategies, and if needed, the development of a personal plan to reduce consumption. Brief interventions can be divided into simple brief interventions, structured advice taking no more than a few minutes, and extended brief interventions, structured therapies taking up to 20-30 minutes and often involving one or more sessions. The frameworks that have been mostly used for implementing brief interventions is the 5 A's framework that has been widely used in smoking cessation, counseling, and other healthy behaviors. And it represents, or it means that the clinicians should take the following actions: asking questions on the consumption and assessing the health status, advising asking permission to give advice and on the reduction, agreeing before proceeding with treatment. It's important to obtain explicit agreement about the treatment plan, and assisting. After agreeing on treatment objectives, physicians should assist patients by identifying and addressing facilitators and barriers.
Lydia, I'm sorry. So participants say they are not seeing the right slides. It's still stuck on audit slide. So yes, now it has moved to brief intervention frameworks. Is it what you wanted to show?
Yeah.
Okay, thank you.
Now it moves?
Yes.
Okay, so as I said, brief intervention frameworks mostly used are the 5 A's framework, as ask, assess, advise, agree, and assist, or the frames one that involves and includes motivation interviewing components, includes giving feedback on the person's intake, giving or providing the responsibility to change into the patients. I mean, promoting the responsibility for change into the patients, offering advice, listing a menu of options for behavioral change, having an empathic approach, and building self-efficacy in the person receiving the brief intervention. This is mainly the main difference is that this includes more motivation interviewing components. And finally, referral to treatment is based on the stepped care approach that, as you know, has many good reasons to be promoted, because it optimizes human resources and it has a lot of benefits and economical reasons for the health system, and also promotes an effective use of infrastructure. So the specific reason to promote referral to treatment, the stepped care, and then the referral to treatment in the SBI model, is that we can we can have some benefits due to the fact that primary healthcare professionals have a lot of workload. There is a lot of stigma associated to alcohol. Professionals, in some cases, do not have training to manage the most severe cases. And some professionals have fear of being overwhelmed by the problems that they cannot cover, that they cannot manage. We have observed also that providing help when severe cases appear, meaning promoting referral to specialist settings, helps to keep SBI in primary healthcare running. And the success stories that professionals see when people get effective treatment and reduce or recover, help increase the motivation of professionals and fights stigma. A good referral network adds credibility to the SBI strategy, and the implementation of prevention activities needs to take into account not only what are the benefits for patients and for the health system, but also what are the benefits for health professionals. So we have to take into account the needs of the health professionals too. Okay. We know it's SBI is one of the most cost-effective policies promoted by WHO and by other governmental bodies. And the last systematic review by Eileen Kenner showed that participants who receive brief intervention consume less alcohol than minimal or no intervention participants. So the reduction was more than 20 grams per week. And then they identified that these kind of strategies had moderate and quality evidence for reducing alcohol consumption. They also identified that longer counseling duration probably didn't have an additional effect, positive effect. So we need to, this systematic review resulted in telling that we don't have to implement long interventions in order to have this benefit. But what do we know also is that the screening and early intervention in primary healthcare is feasible, but is rarely applied. So we still have a lot of margin of improvement. A high percentage of the hazardous and harmful drinkers who present to primary healthcare each year do not receive brief interventions. Alcohol disorders in primary healthcare are twice as high as in the general population, but the majority of these cases remain untreated, especially if it comes to young adults. Studies have shown that the vast majority of alcohol conversations in primary healthcare are shorter than 1 minute. Thus, what we know is that SBI research does not seem congruent with the realities of everyday practice in healthcare. So that's one of the main problems. We are asking primary healthcare professionals to implement interventions that are short, but are not short enough, or they feel is not short enough on the real consultation experience. It is necessary to accompany a whole practice change with education and postgraduate training of professionals, including interventions for hazardous and harmful alcohol consumption and alcohol dependence in primary healthcare. In our experience, we need to have in mind that the evidence tells us on this lack of implementation is that out of 100 patients in primary healthcare services, we identified that 9 fulfill criteria of alcohol dependence, only 5 will be diagnosed, and only 1 of these patients will receive treatment. So this is the gaps we have regularly in primary healthcare, and that's why we need to still promote the implementation of SBI and referral to treatment in primary healthcare. The challenges and barriers it usually face in implementation of this strategy in primary healthcare are of 4 types. We have from one side the patient factors, the denial of their consumption and problems, and also if they will or not to receive treatment. There are healthcare professionals, mainly their beliefs if the treatment is or the intervention will be effective or not, their feeling and incompetence and self-efficacy and their own motivation. We also face contextual barriers, mainly lack of resources and infrastructures in primary healthcare. And also there are some barriers related with intervention itself, because it's perceived sometimes complex and not compatible with previous practice in primary healthcare. On the top of that, I would like to say that in recent years, there is a lot of evidence on the effectiveness of digital SBI strategies. They are as effective as face-to-face and more cost-effective than doing nothing or doing something not directly therapeutic. However, they also have limited transfer and integration in care processes. And it is necessary to promote the use of an intersectional and cross-cultural approach in the design, implementation, and evaluation of digital health resources and solutions. We need to consider the following. There is high competitiveness and coexistence between digital and alcohol contents from varying sources, public health, but not only, and alcohol, including alcohol industry. And there is a saturation of the mobile phone as an intervention delivery platform, and rapid changes and emerging trends in using digital technologies for health purposes. So we need to have into consideration these elements in order to make a good implementation of these tools. Also we need to remind that in young people's multiple risk factors, multiple substance interventions seem to work better than targeting only alcohol. When it comes to implementation, as I told you, there is a few countries and governments that have invested to ensure countrywide implementation. We undertook a literature review and some contacts with key informants of these countries and jurisdictions where SBI was partially or nationwide or region-wide implemented. And we identified that the main lessons or elements to have into account is that planning is key. So a good planning of the whole implementation is essential. We need to have support from senior staff, but also government and the management structure. We need to identify and have resources and funding, long-term funding and resources, provide training, supervision, and various forms of support, including incentives, if possible, for frontline healthcare professionals. We need to do an adaptation to the local context. We need to, it is key to have an evaluation framework to evaluate the impact, and it's important to have a multi-component implementation approach. When it comes to planning, we in the DeepCS project developed a guidance tool to help the planning for region-wide implementation of SBI, and it's organized in these 7 steps, from initial assessment through implementation, monitoring, and evaluation of the program. The DeepCS tool will be hopefully soon available, made available by the European Commission, because this is a tool owned by the European Commission. But we invested a lot of efforts in making sure that every step, providing clear instructions on what to do in all of these steps to facilitate region-wide implementation. Here I would like to show you some elements that we have developed in the Drink Less program that we are implementing in region-wide in Catalonia. We focus a lot of, we invested a lot of efforts in implementing a multi-component program that includes actions at professional level, organizational level, and general population level. We have developed a training and support strategy that provides continuous training and is organized both digital and on-site. A lot of materials. We have a web and to provide support to health professionals so they can access all the information and tools they need to implement it through this website. And we have implemented a network of reference in primary healthcare to facilitate implementation and training of trainees strategy. At organizational level, we have promoted accreditation of all the activities of the program and all the implementation actions. We have introduced a contractual objective with the Purchaser Institute, so meaning that this is incentivized, this action on SBI is incentivized, its implementation is incentivized both at professional and at primary healthcare center level. We have introduced all the needed tools in the medical records, and we are promoting and supporting the referral to specialists of all all patients with alcohol use disorders. We also do actions at general population level, including materials, development of web actions, and also promoting the awareness and screening week every year. As I said, it is key for us to have what we call the network of alcohol reference, meaning one or two professionals, both medical doctors and nurses from each primary healthcare center of Catalonia taking part of this network. So they are the responsible of doing the training of trainers as approach so that we can reach all professionals in all primary healthcare centers. And these are professionals that support us in the implementation and also in the evaluation of the project. We, as I said before, it is key to have an evaluation framework in order to make sure that we collect the indicators and can have a clear idea on the impact at individual, but also at population level. And it's important to have indicators in all the domains. For example, we use the REAIM model, and we need to prepare and plan this implementation in order to be able to collect all these indicators and to have a clear idea on the impact you are having. Both, not only the reach, but also the adoption, the level of adoption and the level of implementation. Again, it is key to raise awareness among general population, and here you have some examples of some activities we are doing in Catalonia. We promote self-assessment of risky drinking by providing several tools and also provide individualized advice in an anonymous way. And we promote what we call as you know, the Alcohol Awareness Week. And we adapt every year, and we promote during 1 week a lot of actions in order to reduce, to promote less consumption of alcohol, reduction of alcohol consumption, and also to raise awareness on the risk of alcohol consumption. As a matter of conclusions of this part of the webinar, I would like to say that it's key to anchor the program, whatever you're doing on SBI at region-wide level, in a governmental institution, so that you can make sure this will be sustained, the implementation will be sustained, and we need to embed this this program in the strategical, regional, and national health planning tools. So unless you have a framework, an institutional framework, and an institutional anchor of the program, it will be difficult to sustain it over the years. We need to make sure that these prevention activities, mainly on alcohol but other risk factors, is considered a priority for primary healthcare professionals. So it is has to be included also in the strategic tools for primary healthcare. We need to make sure that the screening and brief intervention registry tools are part of the daily consultancy tools and the medical records, and we need to provide guidance on how to register activity to improve fidelity and quality of this registration, because usually you can face that these registries are not made correctly, and you cannot monitor the impact of the work you are doing. This SBI should be part of a stepped care approach, and you need to ensure addiction referral to specialist centers. You need to develop continuous training opportunities, e-learning and face-to-face to tackle frequent professionals turnover and acknowledge professionals via economic incentives, if possible, of other means. It is key to repeat and enhance raising awareness campaigns and iterate and implement action research and evaluate impact at patient and population level. Finally, changes are possible, but rather slow and need iteration, a multi-component and a strategic approach. The involvement of all stakeholders and continuous investment and support is essential. Thank you very much for your attention, and sorry for all the technical problems I have faced this morning. Thank you.
Thank you very much, Lidia and Hugo, for your such comprehensive presentations, and also for reiterating that wider adoption of tailored prevention, treatment, and recovery strategies needs to be a top public health priority. I see some questions in the chat, and I hope we will be able to answer at least one or two of them. So the first question is to Lidia, mostly. Is there any difference between the efficacy of the screening and brief interventions provided by different healthcare providers?
Well, there is enough evidence and good evidence both for medical doctors and nurses, and there is also some evidence on social workers and occupational health workers. So in primary healthcare, we have to not only have it's important that all professionals are involved as much as possible, but you need to leave to the local context and the local needs the decision on who should take action on this. But there is enough evidence, and this should be promoted.
Thanks a lot, Lidia. The next question is from Maria to both of you, to Hugo and Lidia. In your personal experience, what are the major differences in delivering SBI for different psychoactive substances? For instance, major groups, tobacco, alcohol, and illicit drugs. The second part of the question is, what are the experiences of stigma, readiness of patients to talk about their use, and what are the practical implications for providers of SBI? Who would like to pick up this question?
I go to the first one.
Please, Lidia. Yeah.
Well, yeah, it's an important question. Right now, if you do not enforce alcohol SBI, usually primary healthcare professionals will focus mainly on tobacco. So that's a reality, because they have more, they feel more confident, and actually the current framework, convention framework on tobacco makes it easier. They feel more like supported, so that the society is supporting this kind of strategies. It's not the case for alcohol, so they usually professionals feel alone in promoting the reduction of alcohol, when at the same time there is, for example, in our context, a lot of advertisings promoting consumption, etc. So they feel somehow alone. They feel that they are the only ones promoting alcohol reduction, alcohol reduction. So you need to enforce and support these alcohol SBI strategies. And it is and that's for alcohol, and it's even more difficult for other drugs like cannabis, but for different reasons. For cannabis and heroin, cocaine, for example, they feel they actually do not know how to approach this. There is a lot of lack of knowledge on the implication of all these drugs in the consumption, and also they fear opening the Pandora box. No, what will come after this? So tobacco is easier. Alcohol should be promoted and endorsed by government and initiatives, because right now, unless you do that, they won't do it. And next step will be cannabis, cocaine, etc. But unless we have alcohol, that is the most used drug, and it doesn't make sense to expand to other drugs, because this is should be the first and the key action in primary healthcare: tobacco and alcohol, because they are the most consumed. And as we need to go step by step. Sorry, I was long, but I wanted to explain all this.
Thanks a lot, Lidia. So probably we can take one last question. This is a question from Gregor. You have mentioned that it's difficult to motivate low risk and hazardous drinkers to use audit and support. Do you think that WHO intention and slogan, less is better, nothing is best, supports or rather discourages people to ask for help and treatment?
I think it's a very realistic slogan, and facilitate this message that many goals are feasible, and it's a patient or a user decision, which is the goal that can commit. So I think it helps that to see the treatment not only as abstinence or no treatment. This dichotomy, it's very bad for the patients, I think. But this slogan helps to understand that the treatment is a personal decision, and you have to negotiate with your doctor, which is your objective. So I think it's a good slogan.
Thank you, Hugo. Thank you, Lidia. Thank you, everyone. Does anyone want to add something? Okay. Thank you very much for joining us today, and everyone have a great day. Thank you.